Here we'll talk about G6PD deficiency. It is an X-linked recessive condition. That's why you can see most commonly in the males. So what is happening here? In case of this glycolysis pathway, there is one rate limiting step. In that rate limiting step, G6PD is a rate limiting enzyme, right? So in case of normal glycolysis, this G6PD will produce NADPH. This NADPH will be responsible for production of glutathione. So this glutathione will cause protection against oxidative stress, right? What happens in case of G6PD deficiency? There is no G6PD, then there is no NADPH. If there is no NADPH, then there will be no glutathione. So if there is no glutathione, there will be no protection against oxidative stress, right? So H2O2 accumulates, which will cause free radical damage of RBC, right? So there will be free radical damage to the RBC, which will cause hemolysis. So the RBC breakdowns, which will cause hemolysis. There will be increase in LDH, decrease in haptoglobin and anemia. So why is this LDH increasing? See what is happening here. In RBC, it has oxygen carrying capacity. So if there is any damage, free radical damage to this RBC, this won't function properly. There will be no oxygen carrying capacity. Oxygen is not transported. So there will be no aerobic respiration. Ultimately, it goes into anaerobic respiration. In the anaerobic respiration, there will be increase in lactate. So which will be increasing lactate dehydrogenase. So that is what is happening here. Now coming to this haptoglobin, it usually RBC binds to this haptoglobin. But here there is lysis of this RBC. So there is no one to bind with haptoglobin. That's why this haptoglobin decreases. Again RBC lysis, which will be leading to hemolysis, causing this anemia. RBC all lysed, so leading to anemia, right? So these are the different things which is happening in one scenario. Coming to the other scenario, what is happening there? There is sulfhydryl group cross-linking in the hemoglobin. So one hemoglobin, other hemoglobin, the sulfhydryl groups are cross-linking, which will be leading to the formation of Haynes bodies. So this Haynes bodies, once it passes into this splenic macrophages, the macrophages take a bite of this Haynes bodies, leading to the bite cells, right? And so there is two types of G6PD deficiency. One is A negative and second is Mediterranean. In the A negative, there is previous exposure to the primaquine. So that is this A negative type. And coming to the Mediterranean, it is the most severe form of this G6PD. It is most commonly seen in Indians and it can usually present with neonatal jaundice, right? So these are some triggering factors for this G6PD deficiency. One is primaquine, anti-malarial, fava beans, sulfonamides, antibiotics, antipyretics, nitrofurantoin, methylene blue, dapsone, sulfonamides and dapsone, remember it. And the infections are the most common form of triggering factors. Infections like pneumonia, hepatitis and all. And flava beans, which is also called as favism. When you take this flava beans, it can also trigger this oxidative stress. So all this creates this oxidative stressful conditions, which will lead to episodic jaundice, pallor and hemoglobinuria. So why is pallor? Because of anemia. So why is this jaundice? Because of hemolysis, there will be increased bilirubin, leading to jaundice. And hemoglobinuria, this hemoglobin is going into urine, that is hemoglobinuria, right? Because of the hemolysis, hemoglobinuria can be seen. So in the acute conditions, what are the three things which you can see? One is anemia, hemoglobinuria, hemoglobinemia. Remember it, hemoglobinuria, hemoglobinemia, anemia. These are the three things which you can see in acute condition. Coming to the lab findings, again decreased haptoglobin because there is no RBC to bind with haptoglobin, so the haptoglobin decreases. If RBC lysis, because of hemolysis, there will be decreased aerobic, increased anaerobic respiration, leading to lactate increase, hemoglobinuria, hemoglobinemia and unconjugated bilirubin, which will lead to jaundice, anemia, Haynes bodies and bite cells can be seen. How are these Haynes bodies are formed? So sulfhydryl groups of one hemoglobin and sulfhydryl groups of other hemoglobin cross react and forms this Haynes bodies. And so this macrophages will take a bite of this Haynes bodies, leading to bite cells, right? So reticulocytosis can also be seen in lab findings. So the specific test which you can do for this G6PD deficiency is methemoglobin reduction test. And G6PD activity of the red cell can also be noted for this confirmation of diagnosis. And treatment, avoid this oxidative stressful conditions which include this primaquine, fava beans, sulfonides, antibiotics, antipyretics, dapsone, methylene blue and infections and fava beans, right? So avoid this oxidative stress. If there is any jaundice or any other symptoms, you can give symptomatic treatment, and antioxidants can also be given, right? So if you see the clinical features in the acute conditions, three things can be seen. One is anemia, hemoglobinuria, hemoglobinemia, and it will be occurring as episodic, not continuous but episodic attacks of pallor, jaundice, hemoglobinuria. And syndromes which can be seen are 3 syndromes. One is acute hemolytic anemia, which we have said here, right? All this story. So that is acute hemolytic anemia. This is intravascular hemolysis. Second thing is neonatal jaundice. It can be seen in Mediterranean type, which can progress to kernicterus and death of the baby, right? So it can be second syndrome associated is neonatal jaundice. And coming to the third one, which is chronic non-spirocytic hemolytic anemia. So if it is chronic, there will be presence of male child. Is usually seen in male child with neonatal jaundice who is presenting with this severe form of this Mediterranean G6PD and also has chronic anemia. So he will be needing recurrent transfusions as the treatment. So what you can see in this CNSHS, so what you can see in this condition, you can see reticulocytosis, gallstones, splenomegaly, extravascular hemolysis. So usually in this G6PD, it involves intravascular. So it involves intravascular in most of the cases, but in the later stages or in the severe form, it can involve extravascular hemolysis also. So this is what said here. So if we summarize the whole thing, in the G6PD deficiency, there is deficiency of this rate limiting enzyme called G6PD. If there is no G6PD, there is no NADPH. If there is no NADPH, there is no glutathione. If there is no glutathione, there is no one to protect RBC from oxidative stress, right? So no protection. So what happens? There is no protection. It will lead to H2O2 accumulation, making the RBC prone to this free radical damage. So once the free radical damage happens, this RBC causes hemolysis, intravascular hemolysis leading to LDH increase, haptoglobin decrease, anemia and all. And the second thing which can happen is sulfhydryl group cross links between hemoglobin leading to Hen's bodies and Pite cells. So two types, one is my A minus and second is Mediterranean. Mediterranean is the most common form seen in Indians and severe form, and also it can present with neonatal jaundice. In the A negative is seen in the person who are exposed to primaquine, right? So what are the triggering factors? It's the most important part of this video. The triggering factors include anti-malarials like primaquine, important to remember, and fava beans, sulfonamides, dapsone, antibiotics, antipyretics, methylene blue, nitrofurantoin, right? Methylene blue, nitrofurantoin. And infections are the most common cause, pneumonia and hepatitis. Coming to fava beans, it's also called as favism. So all this will be triggering this oxidative stressful conditions leading to episodic jaundice, pallor, hemoglobinuria. In the acute stages, anemia, hemoglobinuria, hemoglobinemia. In the lab findings, again you can see all of this. The test is Smith hemoglobin reduction test. Treatment, avoid oxidative stress, and symptomatic treatment and antioxidants. So first thing in the acute, you can see all this three, right? And episodic attacks can be seen. And the three symptoms which are associated is, one is intravascular hemolysis, acute hemolytic anemia. Second is, which you can see in this Mediterranean type, that is neonatal jaundice. So remember, out of these two types, A negative and the Mediterranean is a severe form which can be seen in Indians, right? So you can see neonatal jaundice, and if the neonatal jaundice is not treated in the proper time, it can lead to kernicterus and the death of the baby. And chronic non-spirocytic hemolytic anemia can also be seen as a third syndrome, where there will be end stage. So there will be extravascular hemolysis, gallstones formation, splenomegaly, reticulocytosis and all. And this chronic refers to, it's a chronic condition usually seen in male child with neonatal jaundice and anemia, chronic anemia, and recurrent transfusions will be needed as a treatment. So this is about it. Bye.